Alright, so we're going to pick up with the next portion of the lecture for OBGYN, talking about syphilis. Remember, that's Treponema pallidum, which is that organism that causes syphilis. Remember, this can actually cross the placenta and infect the fetus if the mother is positive for syphilis. And then that can cause way more problems. So it can cause intrauterine death, or for that patient to be, or the baby to be born with congenital syphilis that typically causes blindness, deafness. They can be paralyzed or even be insane. So we would just actually draw another tube, a chemistry tube, to do that VDRL and RPR. And this is something that we can report out to our physicians. So if that patient is positive, we can go ahead and start treatment for that. We're also going to check for rubella and do that rubella antibody titer. If they come back and they show that they lack immunity, we're going to make sure that they become immunized within the first 6 weeks after delivery so that they can be building up some immunity for that. And then with our Rh antibody titer on our Rh negative blood specimens, remember this is going to detect those Rh antibodies that are against the red blood cells, and we're going to see if those women are Rh negative that carry an Rh positive fetus. So we got to be very careful and draw those labs to make sure if they are positive that we are very careful, because we want to prevent any measures where there's an Rh negative woman with potential of having an Rh positive baby, because they're going to need RhoGAM, which is an IM injection that the mother gets, and that's not too bad, but we want to try to avoid that if at all possible. So that first injection, it's normally administered about 28 weeks, and then they'll give that next injection about 72 hours after delivery. Alright, and hepatitis B and HIV, we can check for those. There is a medication that patients can take, a series of 3 shots for hepatitis B, and typically that's going to protect that patient if they can build up immunity. If they test positive, of course we need to take precaution whenever we are delivering that baby, because it can be delivered and pass through the placenta. And also, this is actually part of the new childhood immunizations that babies receive. They actually get the whole series of hepatitis B. We want to be very, very careful if the mother tests positive. HIV, believe it or not, you can have an HIV positive mother that has an HIV negative baby. It's that's our goal, but it's something that we can see. We want to do those antiviral drugs or retroviral drugs that we administer to the mother, and try to do that delivery C-section versus the vaginal delivery. Okay, so we would do, of course, that follow-up testing on that baby during their well-child visits after they've been born, do some follow-up HIV testing. So what about the return prenatal visits? We've talked about everything that's included with that very first visit, so now let's talk about the return prenatal visits. We're going to do those and try to continue to look for abnormalities, any problems that might appear, so we can do the proper treatment. Let's look at the interval that we need to do these prenatal visits. So after that first prenatal visit, the very first one, we're going to do every 4 weeks from weeks 0 to 28. Then once they reach week 29 through weeks 35, we'll see them on an every 2-week basis. Then starting at week 36, we'll see them every week until they deliver. Most of your patients are going to make it to 36 weeks, and they will be able to come and see you on a weekly basis. So you can see how there's a lot of rapid changes occurring at 36 weeks and up through delivery. Some of your patients that are pregnant with multiples, they may not make it to 36 weeks. The goal for patients that are pregnant with twins and triplets, we're trying to get them to 34 weeks because we want those lungs to be nice and formed and as healthy as possible before those babies enter the world. So when we're seeing them on those return visits, we're trying to just continue that rapport with the patient. We're trying to make sure that if they have any more questions about what's going on, we're trying to answer those questions, making sure that they know what's to come. We're going to get a urine specimen. We're going to again check to see if there's any sugar or protein in their urine and make sure that they're not spilling over too much if there is some. We want to check their vital signs. We're looking at blood pressure to see if they have hypotension or hypertension. With hypotension, that's going to occur less frequently, but that could happen because of the way that the baby is positioned in the mother's uterus. But this is something that we have to measure for. The physician will actually measure the fundal height and assess the fetal heart rate. Then we'll assist them in doing the pelvic exam if that's necessary. All right, so we will see that the fundus is typically palpable between weeks 8 and 13, and we can start seeing how that uterus is starting to stretch and make that fundus that nice dome-shaped portion between the fallopian tubes. And that's the part that you'll actually see contracting when the mother goes into labor. So the physician will do those fundal height measurements, and that typically gives us some information as to how much the baby has formed. It also can give us some information about if the baby's not growing very well and if there's a lack to thrive. So that also lets us know about some abnormalities, not just the good stuff. The fetal heart rate, this is something that we want to assess each time they come in. We're looking at finding a heart rate that goes between 120 to 160 beats per minute. And if we go anything below 120, that's really going to indicate that there's some fetal distress. So we don't want that to happen. And they use a Doppler ultrasound to look through the abdomen with those ultrasonic waves to catch that heart rate. And this is what those fetal heart monitor looks like. So they're actually catching those tones through ultrasonic waves. Okay, so as the baby continues to grow, that sound becomes more audible and you're not having to search for it quite so hard as you are whenever the mother is early on pregnant. Alright, so there are some other things that we want to look at. Fetal heart tones are just really, really important. And we use a gel. Typically it's just a regular lubricant like KY jelly or a Doppler type of gel that actually promotes the sounds to go from the skin to the transducer. And each time we do that, we want to make sure we clean off that probe very well. And I believe they actually sell these over the counter now, so patients can actually listen for their baby's heartbeat while they're at home. So the reason we do this is to confirm that there is still a beating heart in there, and that's really important, really, really important. It does put the mother's mind at ease when they hear that little heartbeat. Then we talk about the vaginal exam. We want to make sure that we don't have any parts of the baby trying to stick out in an early fashion. Plus we want to make sure that there's not any cervical dilation and effacement that's occurring too early. The multiple marker test is performed between 15 and 20 weeks, and it's typically used to detect for things like Down syndrome, and that's what I referred to earlier in the lecture as the triple screen, but they've actually added a new one, so it's a quad screen. And this is something that the mother has the opportunity to either elect to have done or not to have done. Some people, just have their personal beliefs about this particular test, and that lies with the patient. Then we have the ultrasounds. That's the fun part, because everybody wants to see how their baby's growing. And this is actually, in my opinion, this is fun, but it's also very scary, because what happens when you throw that ultrasound transducer on someone's belly and they don't see a heartbeat? That's always in the back of my mind. But why do we do these ultrasounds? Well, we want to see how the baby is developing, making sure that they are developing all their bones and their organs, and the placenta's in the right place, there's enough amniotic fluid, all of those fun things is what we're looking for, being the purpose of the ultrasound during pregnancy. So that tends to be done on a regular basis. I think there's at least 3 or 4 that the pregnant mother gets to have done. There are times that a patient has to have an amniocentesis, and that would be because there was a abnormality detected in lab work, or maybe detected within a ultrasound. So typically those are performed within the 15 and 18 week time period, and it's going to help us further diagnose things such as congenital abnormalities like Down syndrome with a chromosome disorder. This is definitely a easy procedure that the physician can do in the office now, but it is high risk. You definitely want to have your patient go home and rest after that is done. Alright, sometimes people have those amnios to determine if it's a male or female. That's kind of jumping overboard, and I don't know why doctors do that, but it is one of the ways to get your almost 100% known boy or girl for your patient that's pregnant. Alright, so what do? We use this long 4-inch needle to go through the abdominal wall into the amniotic sac that surrounds the baby, and it's like their little swimming pool. Then we hook a syringe up to that particular needle. We call them spinal needles, and we withdraw some of that amniotic fluid. Now, that fluid should look really clear and pretty, almost like a nice clean urine, and that tells us a lot of good stuff if we see it's nice and pretty and clear when it's aspirated. Typically, once it's sent to the laboratory, you get your results within 1 to 3 weeks. Now, with that amniocentesis, you do have a slight risk of bleeding, leakage of fluid, infection, and even a miscarriage. So that's why I said earlier, it's not a procedure that you just want to go jump and do just because you want to know the sex of a baby. Okay, it is offered only to women of high risk, or for fetal abnormalities, or again if there's some abnormality with some lab results or an ultrasound. Okay, so sometimes during pregnancy we have to do some fetal heart rate monitoring, especially when those women get very pregnant and they're past their due date, because we want to make sure that the baby's not in any kind of distress. And we definitely want to be very careful about that. The physician actually, with the fetal heart rate monitoring, they implant a monitor vaginally, and it actually sticks to the top of the baby's head and then projects the sound through the electrodes, and we print out information on the paper. And that's typically what you will see while the mother's in labor as well. Alright, so what about those return prenatal visits? What are we going to be doing? The big things we have to remember to do: make sure we have all of our stuff together when we go into the exam room to assist the physician with the exam. We want to make sure that we have all the information updated on that prenatal record. We want our patient to be prepared and be well understood as to what's going to happen. We want to do that urine test, get those vitals, and make sure that the weight's included there. Now, let's go to the part where we've had the baby, all that excitement's there. Now we're coming in for those postnatal types of exams. So that this is that really strange word where it's puerperium, and this is the period of time when the mother's body is having all of its systems trying to return to its pre-pregnant state. So if you can imagine the hormone rush there, this takes about 4 to 6 weeks to occur, and the uterus is going to continue to contract and try to go back down to a normal size, but there is no normal anymore in my opinion. Okay, so we might see some discharge, which is termed lochia. So this is the discharge from the uterus after delivery. So the color tells us at what stage the uterus is at returning to its normal state. So that usually goes away within about the 3rd week, but sometimes it can last all the way to the 6-week period. Okay, so we definitely want to tell our patients to be careful. Their body is trying to go through this big transition. Try not to overexert themselves to become fatigued. Don't do any heavy lifting, and try to eat a well-balanced diet, especially if they're nursing. Okay, so at that 6-week visit, when they come back to see you, what we're going to do is we're going to evaluate their general well-being, and we're going to make sure that there's no residual problems after having that baby. So we definitely want to make sure they're not having any problems with postpartum depression, vaginal discharge, urine or bowel dysfunctions, or any problems with breastfeeding. Okay, so here are the things that go on within that 6-week postpartum visit. The evaluation of the pelvis, looking at how, if they had a episiotomy, if that's healing well. If they had a C-section, is the abdominal wall healing well still after they've had their sutures removed about 10 days after they had their C-section. Then also we might need to do another H&H to see if they're anemic. So again, even at that 6-week period, what are we responsible for? Measuring and recording vital signs, measuring their weight, and then preparing that patient for the visit and assisting the physician. And that's the end.